Good morning or good noon. We are funded by our projects are funded by the European Commission, the ARC, the Belgian Cancer Foundation, and I was able to come here as an invited speaker, and the organizers have sponsored my trip to here. Today I will talk now on the situation on cervical cancer screening in the developed world. We will discuss screening systems and policies which are in place in North America, Europe, Japan, and Oceania. And in particular, and I will end by this, I will discuss how to change from cytology-based to HPV-based screening in high-resource countries. First, a few words about the burden of cervical cancer. So the developed world, that means the countries surrounded here in blue, North America, Europe, in Asia, Japan, and in Oceania, Australia, and New Zealand. You see that in this part of the world, the dominating color is green or pink yellow. This means a quite low burden of disease. In summary, in the first column, you have some data on the burden in developed countries, and this contrasts with the last column, the situation in less developed countries, already discussed by the previous speaker. The risk of having cervical cancer, developing cervical cancer before the age of 75 is less than 1% in the developed world. It's double in less developed countries. If we look at the range of lowest and highest mortality for the more developed countries, it is from very low to, in some countries, 2%. In the less developed countries, we also can see very low incidence, but it goes up to 6% in some West African countries. 6% of women that develop cervical cancer before they reach the age of 75. Also, the mortality rate is 2 to 3 times higher in less developed countries compared to more developed. But also, within the developed world, there are important contrasts. And I have plotted here the situation in the European Union, which contains 27 countries. And the contrast between Finland at the bottom and in Romania, in terms of mortality, differs by a factor of 11. In Romania, proportionally 11 times more women die from cervical cancer. In Romania, there is no screening. In Finland, there is a well-developed screening program, which we will discuss later. Now, in Europe, in 2003, all ministers of the Union have met, and there was a political endorsement of a scientific consensus that organized screening should be offered for 3 cancers: for colon, for breast, also for cervix. And for cervix, the test proposed at that time was the pap smear. Screening should be started preferentially in the age range 25-30, but certainly not before the age of 20. And it could be interrupted from the age of 60-65, depending on the local situation and resources. And the interval for cytological screening should be 3 to 5 years. And what was stressed in that council recommendation was that screening should be offered only in organized programs, and that evidence-based guidelines should be developed to support clinicians and decision makers to develop their policies. And this was then translated in the second edition of the European Guidelines in Quality Assurance and Cervical Cancer Screening. And as I mentioned, the screen test recommended was cytology. So it was a guideline published in 2008 based on evidence available in 2007. HPV-based screening was not yet recommended at that time. It was stated that we still needed a higher level of evidence. We knew already that there was, as was shown by the previous speaker, that HPV is more sensitive than cytology, but we could not distinguish between higher detection of real progressive disease and regressive CN2+. And we wanted in Europe, we wanted to observe randomized evidence, and the outcome we were looking for from randomized trials was a reduction in the burden of CN3 and cancer in the second screening round among women who were in the screening in the HPV screening arm versus the cytology arm. Now, a few words on the different systems and policies in place in high-resource countries or developed countries. The two systems are organized screening and opportunistic screening. So what are the characteristics of organized screening? First of all, there should be a defined screening policy where the test, the recommended test, is clearly defined. The target age group, the start and the end of screening, is established, as well as the screening interval. In an organized program, there should be scheduled invitations. There should be quality control at all levels. And this includes registration and participation. Registration of the test results, and these test results linked to the further follow-up and the cancer registry. Organized screening should involve an evaluation of the process and impact using individual patient data. It has been shown, and I will give some slides to prove that organized screening is more efficient and often more effective. And organized screening is observed today in Oceania, Australia, New Zealand, in a few European countries, essentially situated in the Nordic region. But there are a few new countries in Europe where organized screening has been started, such as Ireland and Slovenia. And organized screening at the subnational level is also in place in Italy and Canada. Now, organized screening contrasts with opportunistic screening, whereas the screening depends on the initiative of the individual woman or her physician. There are no invitations. Quality control can vary between countries, but is essentially based on the screening test. There is no registration or certainly no linkage between screening and the cancer registry. The evaluation is not based on individual data, but on aggregated data, if there is an evaluation. The effectiveness noted in non-organized countries is variable. In non-organized screening, we often see the coincidence of overscreening with poor coverage, and poor coverage essentially in the more social vulnerable groups of the society. And also typical for opportunistic screening is an uncontrolled introduction of new technologies. Now, opportunistic screening is the main type of screening in the US, in the major part of Canada, Japan, and in most other European countries. So here you see an overview for the European Union. In blue, you have, in dark blue, the countries with established screening. In pale blue, screening applied at the subnational level. And then some blue symbols that are local programs where pilot projects are going on. So organized screening, we see it in the north, in Finland, Sweden, Denmark, Also Norway, but this is not colored because it's not a member state of the European Union. In Northwest Europe, we have the UK, Netherlands, and Ireland. In Southern Europe, parts of Italy. In Eastern Europe, Slovenia. And there's also, let's say, a tentative organized program in Hungary. And it has been decided to roll out organized screening also in some East European countries, in Poland, Estland, Lithuania, and Latvia. Now here are a few descriptions of the policies existing, and I just take Europe here again. The screening intervals in the European Union varies between 1 and 5 years. The starting age, there are a few countries that recommend screening starting at the age of 15. Of course, this is not a European policy. Most countries start at 25, but in Finland and the Netherlands, screening starts only at 30. Screening stops at 59, and some countries go up to 70, and there are even countries where there are no limits, no age limits about screening. Now I will discuss that in the next slide. It's clear that more pap smear does not result in lower incidence of cervical cancer or mortality from cervical cancer. As everywhere, the population coverage is the main factor of success. In the Nordic countries, we see coverages which are in the range of 70, 80%, and sometimes higher. And the incidence there has lowered over time, as I will discuss in one of the next slides. In Romania, the country with the highest burden of disease in the European Union, the coverage, in fact, we do not know it very well, but it must be somewhere around 10%. And in several countries, we do not know what the coverage exactly is. Now, in my previous slide, I say that more pap smear does not result in lower incidence. We see here in a paper from Dick Habema, published this year, you see here the intensity of screening expressed as number of smears per 1,000 women per year. And we see in the, we have some light. We see here the curve for the US, and here the curve for the Netherlands. And here we see the trend of the incidence of cervical cancer over time, and we do not see a difference between the US and the Netherlands, whereas the intensity of screening in the US was 4 times higher compared to the Netherlands. This slide was already shown by Dr. Carlos, so we can skip it, or maybe just we can point to the red curve in Norway, where we do not see, if we look at the situation from the 70s up to the late 90s, we do not see a clear evolution, whereas in other countries where organized screening existed, there was a substantial drop, which was sometimes already observed earlier, like in Finland. In Norway, we do not see that. Norway did not have an organized program. We have clear evidence on the effectiveness of organized screening from Finland. This is a not so recent case control study. Nevertheless, it provides still clear evidence that organized screening is very effective. The odds ratio for women participating in organized screening compared to a non-screened women was 0.25. It was significantly lower than 1, and lower than 1 means that screening is protective. Opportunistic screening was also protective, but it was not statistically significant because, yeah, the size of the case control study was limited. But, and the last line is even the most important one, women that, in addition to organized screening, also participate in non-organized screening do not have a lower odds ratio. They do not have an additional advantage beyond organized screening. So in Norway, you have seen the graph up to the late 90s. You see here in this graph, from the early 90s up to half the 2000s, I think, you have in blue the situation before the introduction of organized screening, and this was in the mid-90s, and in blue, yes, and then in red after the introduction of organized screening. And you see that in the young age groups at the left, the high coverage is maintained, it's even slightly higher, but in the age groups where the coverage was low, the coverage becomes now substantially higher in the organized period. Overall, the coverage has dropped with increased with 7%, but the pap smear use has decreased. So with less smears, they arrived at a higher coverage, and in the meanwhile, the incidence has decreased with 22%. So this is clear, observed evidence that organization adds to opportunistic screening. Now I come to the last part of my presentation, the application of HPV testing. There are three major indications for HPV testing, and I will cite them in the order that evidence was generated. The first application is the triage of women with minor abnormalities, and there's clear evidence, robust evidence, that it is effective and very sensitive in ASCUS triage, but not so in low cell. But the evidence varies from country to country for low cell triage. Another indication is as a test of cure after treatment of high-grade CIN. And last but not least, in primary screening, where we can distinguish co-testing. And co-testing is now the policy for the United States, where triage is done by cytology or by HPV genotyping for HPV types 16 or 18. Screening, co-testing is recommended over the age of 30 in the USA. Now in Europe, 5 randomized trials have taken place, and the results of them are decisive now in switching from cytology-based screening to HPV-based screening. And in Europe, it will be recommended to use HPV testing alone as the screening test, and cytology will only be restricted to women who are HPV positive. And the evidence for this European policy comes from these T graphs, which are a part of Xavier's Bosch HPV monograph, which you all have received and which you have in your bag. So at left you see the very consistent reduction of CN3+ in the second screening round, observed in women who were HPV negative in the first round compared to women who were cytology negative in the first round. So in spite of the different policies used in 4 trials, we see a very consistent, there is absence of homogeneity in the incidence of CN3. And remember, in 2008 in Europe we said we need this evidence to switch to HPV-based screening. Today we have that evidence, so we should in Europe switch to HPV-based screening. And in spite of the fact that the trials were not empowered to demonstrate reduction in invasive cervical cancer, Now, with some data received from the authors, we see that even for the outcome invasive cervical cancer, we see a consistent reduction. And if we pool that, it is statistically significant. So I've shown that cytology screening is effective. Now, HPV-based screening is even more effective. Now, a few maps that we have made with the European Federation of Colposcopy. You see here the countries that have introduced HPV-based triage, and the different colors indicate whether it is used only for ascus or also for low-sil, or even in some countries for atypical glandular cells. So most Europes apply some type of triage. And then a last one, these are data which I have received from a colleague working in the PREDICT network, Miriam Elfström. This is very preliminary. The data collection for most countries is still going on, but you see that there are today at least 6 countries that have introduced HPV-based testing in post-treatment follow-up. But there are more. Now, to conclude, we have seen that organized screening is in principle more effective and certainly more cost-effective than opportunistic screening. Nevertheless, the less efficient opportunistic screening still dominates in the European Union and in North America. Setting up a well-organized screening program is not simple, it's complex. It requires a high level of competence, organization, and planning. And it takes often many years to roll it out. And this is what we have seen also in Norway. HPV screening can increase the effectiveness and can allow for screening at longer intervals, but that's very easy to say. It's not so easy to implement. So the general message of all screening, whatever the screening test is, you should organize it, but a fortiori with HPV screening, you should be instructed to organize it before introducing it, because there are some risks. HPV screening in young women is not effective. It generates adverse effects, and we have to compensate for the loss in specificity by applying longer intervals and by applying good triage methods. So I think this was my last slide. So, dear Chairman and colleagues, dear participants here in this meeting, thank you very much for your attention.